Welcome everyone to our webinar, The Political Determinants of Health and Climate Change Strategies for Promoting Environmental Justice. Before we begin, all of us at the Medical Society Consortium on Climate and Health respectfully acknowledge that our advocacy, education, and learning across the country takes place on the occupied and unceded lands of many Native American tribes. To acknowledge this lands is to recognize its long history and our place in that history. It is to recognize these lands and waters and their significance for the peoples who lived and continue to live in this country and whose practices and spiritualities were, are, and shall always be tied to the land and the water. Today's webinar is the fifth in our 2024 Climate and Health Equity webinar series as part of the Climate and Health Equity Fellowship Program. The CHEF program recognizes the need for more diversity in climate and health leadership and a sharper focus on equitable climate solutions. The goal of the fellowship is to empower doctors of color from populations that face greater burdens from climate effects and are underrepresented in medicine to become leaders in climate and health equity education, advocacy, and policy solutions. I'm Dr. Shanita Johnson, Director of the Climate and Health Equity Fellowship. Also joining me from the consortium to run this webinar are Dr. Venice Curry, Associate Director of the Climate Health Equity Fellowship, Dr. Kimberly Williams, Chef Program Manager, and Clarissa Payton, Chef Program Assistant. Excuse me. Clarissa will be available through the chat to answer any technical questions during the webinar. The webinar series is hosted by the Medical Society Consortium on Climate and Health and is held for 1 hour on the second Friday of each month from 3 to 4 p.m. Eastern Standard Time. Today's webinar will be recorded and made available on our YouTube channel and website for future viewing as part of the Equity Resources page on the consortium's website. This year, we are excited to continue our initiative of offering CME credit for our webinars. Instructions on obtaining credit will be provided at the end of the webinar. The intersection of policy, health, and equity is of paramount importance. Understanding the implications and direct and indirect linkages between policy decisions and their impacts on climate, health, and equity is crucial. Today, we are truly honored to have Dean Daniel Dawes, the founding dean of the nation's first and only School of Global Health, located at Meharry Medical College, join us. Professor Dawes is an internationally recognized leader in the health equity movement who has led numerous efforts to achieve equity in health policy issues, especially those impacting vulnerable, underserved, and marginalized populations. A trailblazer and esteemed voice in the health equity movement, he was instrumental in shaping the Affordable Care Act. His scholarship and leadership, specifically the groundbreaking Political Determinants of Health framework he introduced, have catalyzed the prioritization of health equity through policies and laws. Rather than using our time to provide a further description of his impressive work, we are placing a link to his website, which includes his bio, in the chat. The general format for today's webinar will be a 40-minute presentation by our speaker, followed by 10 to 15 minutes of questions and answers from our audience. We ask that you put comments, links to any resources that you may recommend, or any questions that you may have for our speaker in the chat box at any time during this presentation. We will get to as many of them as we can during the Q&A period. Please do remember to keep yourself muted so we are not interrupted by background noise. Dean Dawes, we are looking forward to your talk. Please begin.
All right, wonderful. Thank you. Thank you so much, Dr. Johnson, for that very warm introduction. Of course, good afternoon, everyone. I don't know if you all can see my slides. Did I upload them correctly? Can you see it? Yes,
Yes, we can.
Yes, all right, beautiful, beautiful. All right, let me put it in presentation mode. But again, good afternoon. It is a real honor to join you. And I have to tell you that Dr. Johnson has, briefed me on the organization, briefed me on all the incredible work that you all have been doing to address the intersection of climate change and health equity. And I'm really happy to talk to you about how we can take what you all have been doing, focus it, right, and more effectively make progress on eliminating health disparities, on mitigating the impacts of climate change, and of course, achieving health equity, which is our ultimate goal as health equity champions, I'm sure. So right now, I'm going to dive into the political determinants of health. We're going to talk about how we can navigate this in an election year and, of course, beyond as we move forward. A lot of us know that health inequities don't occur naturally. They are caused by deliberate action or inaction from some policy decision made or not made in some cases, or from some unmet social need. And enabling and instigating these social determinants is what I call the political determinants of health. You know, many of you might be familiar with Thomas Piketty, the renowned economist. Thomas Piketty, in his years of research, has recently concluded that inequality did not simply emerge from economic reality, from technological change, or the organization or production, nor from inherent disparities in individual talent, ability, or effort. Rather, he argues, inequality is determined through struggles that take place in the political sphere. Let's think about that. It raises an important point. If the resources and the advantages attained through the political sphere are not equally distributed among population groups, then is it any wonder, right, that the health outcomes and the premature deaths are not equally experienced among certain population groups? Well, as I mentioned, many of us know that these health inequities are not by accident. And with that, I really want to share a short video with you highlighting the forces and the factors that have either hindered or enabled health equity for vulnerable and marginalized communities. And it's titled Jessica's Story. So I'm going to start Jessica's story. Let's see if I can get this up and running. And if you can't hear it, please let me know.
To best grasp the political determinants of health, let's examine a hypothetical example that combines experiences of real people in urban and rural communities. Imagine a 19-year-old woman, we'll call her Jessica. After enduring several miscarriages, she barely survives giving birth to an infant 9 weeks early, the baby weighing only 3 pounds. Her son is placed in the neonatal intensive care unit, the blood from his umbilical cord revealing over 200 toxins. Where did the system fail Jessica and her baby? How and why did these results occur? 3 years earlier, Jessica had left her parents' house. Access to treatment for her dad's substance use disorder had been eliminated when policymakers closed 3 of the city's public community health centers to save money. Contending with his wife's lack of education, neither of Jessica's parents could secure a job with a livable wage, prompting serious and substantial mental health conditions. Jessica moved to a low-income neighborhood in the city. She never knew of the extent of how the appalling conditions of her neighborhood were politically determined. For example, determined to keep housing segregation in place, politicians expended very few resources to build sidewalks, parks, or recreational facilities. Healthcare providers refused to operate in Jessica's community due to poor reimbursement rates from Medicaid. Because they resisted creating bus routes, lawmakers dissuaded grocery stores from operating in the community, preventing residents' access to fresh fruit, vegetables, and meat. Simultaneously, policymakers altered zoning laws to permit development of a dump site and a chemical plant, switching the community's water source from a clean river 10 miles away to a nearby polluted river to save money. This water was used to drink, bathe, and wash clothes. It also irrigated the lawn at Jessica's apartment building, adding to the list of pollutants and environmental hazards in her neighborhood. And because her district lacked established tenant rights, her landlord had no interest in improving unhealthy housing practices. Jessica found work as a cashier at the corner convenience store, a job with no employee benefits, including health or disability insurance. Because policymakers rejected proposals to increase minimum wage to a livable income, Jessica often substituted her employer's free snacks policy as a meal, never realizing the effect that high-fat, high-sodium food would eventually have on her or her baby's health. With local politicians striking down an effort to ban smoking in convenience stores, Jessica was constantly subjected to a barrage of secondhand smoke. And when she discovered she was pregnant, no attempt at receiving health insurance coverage was successful. Her non-ACA compliant plan denied her maternity coverage because they viewed her pregnancy as a pre-existing condition. Medicaid, the government's health insurance program for low-income families, denied her coverage for not being poor enough. After finding a ride to the free clinic, Jessica waited more than half a day to be seen by a second-rate physician, a doctor who was condescending and offensive. Realizing she could not afford to take more days off from work, she never went back. At 31 weeks, a neighbor drove Jessica to a hospital ER 20 miles away. Seeing that Jessica was experiencing excessive swelling in her face and ankles, as well as seizures, the emergency team decided to deliver her premature son immediately. Due to complications, her newborn son was sent to the neonatal intensive care unit. Once his organs were deemed mature enough, he was taken off the machines and sent home with severe cognitive defects. And in their apartment, Jessica and the baby were exposed to mildew and cockroaches, causing her son to develop respiratory problems. The landlord refused to remedy the poor conditions, telling her to move if she didn't like it there. Jessica struggled to find early childhood care and access to schools with educational assistance, healthy food options, and other resources needed to thrive. Because their school and community lacked the resources to enable Jessica's son to even barely reach his potential, he dropped out of school after entering 8th grade, just as his grandmother had done, repeating what is surely the ongoing rule of poverty. Jessica's story shows the compounding effect of political determinants over personal responsibility. No matter how reliably Jessica tried to act, structural, institutional, intrapersonal, and interpersonal obstacles stood in her way. Political determinants were pulling strings that prevented Jessica and her family from achieving optimal health and their full potential. What does this mean for all of us? What can we do to improve and mend our community's most damaged systems?
Well, there's certainly a lot that we can do, and we're going to talk about that today. So let me bring this back up with our third slide. Many of us have seen the headlines highlighting the everyday impact of these political determinants of health on our communities, the effects of which can be observed in many areas of health and healthcare, including young children growing up without mothers owing to high maternal mortality rates, poor and minoritized families being funneled into substandard housing by inequitable systems, and of course, for those of you who work with people with mental illness, substance use disorders, many of these with depression and anxiety, PTSD, bipolar disorder, and others have reported twice the odds of being able to access transportation in their communities. You know, all of us have seen over the last several years the struggle to advance health equity in the United States and around the globe, and the levers of politics and policy that have been used at all levels and by all branches of government, quite frankly, to impact the health of our communities. They have affected the health outcomes of all population groups in one way or another. So I want to take a deeper dive into the headlines moving forward. Many of us understand the effects of redline cities and the impact of the Homeowners Loan Corporation Act from the past. We know recent research has demonstrated that formerly redline cities are as much as 12.6 degrees Fahrenheit hotter than non-redline cities, according to a spatial analysis that was done that included 9 New York State regions. The difference in temperature, according to that report, is due to a difference in the tree canopy and the porous surfaces, such as parks and green spaces. When we think about urban heat, right, and the effect that this is having in making cities hotter, we know again that climate change has strong implications and impacts on our health and well-being. Almost 34 million people in 65 major US cities, or 15% of this country's population, are experiencing temperatures that are 8 degrees higher than their surrounding areas. And that's according to a new analysis from Climate Central. We know that a lot of this is largely due to the built environments like parking lots, asphalt, sidewalks, lack of trees that contribute to what is known as that urban heat island. And again, as we're thinking about the effects at the top all the way down to the bottom, we need to understand how layer after layer is impacted by these political determinants of health. Rising sea levels, another major impact from climate change, disrupting millions of Americans. Almost 3 million people are currently living in 703 US coastal cities or coastal communities with critical infrastructure at risk by flooding. And this is an alarming statistics. We know as we think about many of these urban environments, many of these communities, unfortunately, are experiencing climate gentrification. Is it any wonder as we move forward? A lot of these communities, a lot of these population groups were prevented by acts of law and policy from owning real estate by the seashore. They were ironically pushed further inland into higher elevated properties. And now, as the sea levels are rising, we see millions of folks, hundreds of thousands, quite frankly, that are being pushed out of their communities. Across America, we know clean energy plants are being banned, and this is also having an effect faster than they're being built, right? Again, we see the impact that local and state governments are having in weighing in and preventing or allowing, in some cases, right, these infrastructure that would help to mitigate the impacts. When we think about EV batteries, another major headline, the environmental impact of these is quite interesting, quite alarming. Think about this, right? 70% of cobalt comes from the Democratic Republic of Congo. And interestingly enough, we know that 40% of the 255,000 current workers, over 40,000 of these are children, some of them as young as 6 years old. And what is happening to many of these is that despite the potential fatal health effects of prolonged exposure, adult and child miners working without even the basic protective equipment are experiencing higher rates of course, lung disease and other health impacts. We know we could go on and on about these issues. I mean, bringing it back closer to home, when you think about Project 2025, and you think about policy agendas that are being pushed, we should all be concerned that these could have grave implications for the National Weather Service, for our ability to track and mitigate the impact of climate change. Again, they are connected to policy action or inactions, and we will see that as we spell this out. You know, the chances of people dying young differ dramatically across the United States. And according to doctors Meharry and Montez at Syracuse University, this data slice on your screen shows state-level differences in rates of death by ages 30, 50, and 65. As you can see at the top of the screen, individuals living in Minnesota, California, New York, Massachusetts, Utah, Connecticut, and Washington have the lowest rates of death by age 65. Whereas those that live in primarily southern states, including West Virginia, Mississippi, Alabama, Kentucky, Tennessee, Louisiana, Arkansas, Oklahoma, have the highest rates of premature death. And according to these researchers, if current conditions remain constant in these states, more than 1 in 5 people born in them will not survive to the age of 65. Think about that. 20% of their population will not survive to the age of 65. And again, this is alarming in light of the increased impacts of climate change on our health. The 7.1 year difference between the states with the highest life expectancy and the states with the lowest life expectancy is very alarming, even more so when you delve into the data within states. And what's also interesting from a public health standpoint is that although these differences in life expectancies across states have long existed, the magnitude, though, has been fluctuating over time. You know, during the 1960s and the 1970s, states were becoming more alike in terms of life expectancy. They were getting closer and closer. But what happens? However, the convergence ended in the early 1980s, again, when we saw an effort to push for more rugged individualistic focused policies rather than egalitarian or equity focused policies. So I want to delve into that a little bit more because the costs are astronomical. Many of you know Dr. David Satcher's research where he pinpointed that we were losing 83,000 individuals each year. In fact, this was African Americans alone, did not include other racial and ethnic groups. 83,000 African Americans owing to disparities in health status and healthcare. We know that the cost in terms of lives is alarming, but it's also alarming in terms of the financial impact. In 2009, Tom Levis, Daryl Gaskin, and others at Johns Hopkins University did a groundbreaking study to understand what was the economic costs of racial and ethnic health disparities. And they conservatively estimated, based on the publicly sourced data sets that they had, that it was costing us $300 billion at the time. Dr. Levis and Dr. Eliseo Perez-Stable at the National Institute of Minority Health and Health Disparities looked into data in 2000, looked at the 2018 data to see where we were. Had we made improvements? Had we made any progress? And they found that, in fact, progress had been very slow. In that case, they found that in 2018, the number had ballooned to $451 billion. Back in 1984, a group of leaders, David Satcher, Louis Sullivan, and others got together, and they met with Margaret Heckler, who was then Secretary of Health. In there, they implored her to study minority health and health disparities and help the nation understand that while the health of the nation had been improving, the health of African Americans, Latinos, Native Americans, Asian Americans, et cetera, was alarming. And they wanted a task force to really study and understand how we could bring a whole of government approach to the issue. Their conclusion was that in order to bring up the level of health among minoritized groups to those of the general population, we needed some efforts of monumental proportions in order to make that happen. That has not happened politically, and we wonder why we're in the state that we're in. This chart that I'm showing you on your screen is meant to highlight then what happened in the past, where we are in the present, and where we are moving forward into the future. So I talked about Tom Levis's study and his team that looked at $300 billion, then 451 or estimated 451 billion in 2018. Those looked at only physical health conditions. As we know, climate change impacts have significant impact on not only our systemic health, but our mental health and well-being. And so my team and I looked this past year, we just published last month, our report that says, let us connect diseases of the brain to our systemic health and understand what the cost of inequities are presently, where we will be in the next 6 years in 2030, and by the time we become a more racially pluralistic country, a majority minority country, what will the cost of racial and ethnic health disparities be? Looking at our whole health, mind and body. We found that today we are spending $477.5 billion. That, according to both publicly sourced and privately sourced data that we got our hands on, at the rate that we are going, if we do not rein these issues and these problems in and invest the resources needed to tackle them, we will see that cost balloon to $1 trillion. And at that rate, we also expect that by 2040, that number will balloon to $1.3 trillion. Again, looking at both mental and physical health conditions, looking at productivity loss, presenteeism, absenteeism, unemployment, premature deaths, the list goes on. So why is this happening? Well, we know today that there are a variety of forces that are collectively impacting our health and determining the quality and the extent of our lives on this earth. We know that key among these determinants are the social determinants of health, that created the structural conditions in which all of us are born into, we live in, and we die in, that affect all aspects of our health. And of course, these social determinants of health play an outsized role in these human-made pre-existing inequities. But underlying every one of these determinants is a political determinant that we can no longer ignore. You see, too often, we've been stopping at the social drivers of these inequities, failing to look back and to dig deeper to further see the depths of these problems, right? And to understand its root causes and distribution. And as a result, we have been missing the link between the social determinants, the behavioral determinants, the clinical determinants, you name it, and their policy roots. You see, for every social, behavioral, whatever determinant, there was a preceding legislation, regulation, law, case law, ordinance, or other policy decision that resulted in the structural conditions in which you and your patients and your communities find themselves in. You see, in the United States, as well as in other countries of the world, our health is not an organic outcome, as I talked about earlier. It is not a coincidence that certain groups in our country experience higher premature death rates than others. It's not a fluke that some groups experience poverty for generations, blocked from achieving the American dream. Our system, you see, has not always valued each group equally or realized the long-term implications that policies have on the health of their people. Well, in our country, the principal roots of current and historical health inequities are found in the political determinants of health, which have inequitably distributed social, medical, and other determinants. And they have created the structural barriers to equity for population groups who have lacked power and privilege. You see, all political determinants affect every single one of us, whether you are Black, white, Asian, Latino, Native American, Native Hawaiian, Alaska Native, you name it. It affects all of us because they encompass the systematic process of structuring relationships, distributing resources, and administering power. However, there are stark differences in how negatively or how positively they affect certain individuals and communities. We know that political determinants create the structural conditions and the social drivers, including poor environmental conditions, inadequate transportation, unsafe neighborhoods, poor and unstable housing, and lack of healthy food options that affect all dynamics involved in our health. Again, for every social determinant of health, there is an underlying policy decision or a structuring of resources that had enabled those conditions to exist, whether through action or inaction. We know that political determinants of health are evidenced in the research, in the data. Research has shown us over the last several years, thankfully, many of you on this webinar, as well as our colleagues outside, have published, and we have published about 7,000 peer-reviewed journal articles each year over the last 6 years, highlighting that high obesity rates, maternal mortality, infant mortality, gun violence, depression, opioid addiction, substance use disorders, diabetes, heart disease, cancer, HIV/AIDS, you name it, among many other health problems, can be firmly linked back to policy action or inaction. Residential proximity to major highways could significantly increase risk of type 2 diabetes, and it is an independent risk factor for type 2 diabetes. Historically, red line census tracts have significantly higher rates of emergency department visits owing to asthma, suggesting that this discriminatory practice might be contributing to racial and ethnic asthma health-related disparities. We know the list goes on. The increase in voter restriction barriers correlated with 25% higher probability of not having health insurance coverage. We know that that is a critical element in gaining access to vital health services in our communities. Well, let's talk about this a little bit more. To be clear, let's be clear. Health inequities are unfair and avoidable differences in health status that arise from social conditions in which people are born, they grow, they live, they work, and they age. This is caused by no fault of their own. These differences are not merely about genetics or individual choices. They are deeply rooted in social structures and policies. Health equity seeks to address those challenges by ensuring everyone has a fair shot to be as healthy as they possibly can. Fundamental to this work is the core truth that these differences can be reduced or eliminated by taking proper actions or investments. This is important, and it really is an essential distinction that the political determinants of health makes. And so as we continue to develop the interventions to address these issues, it's worth noting that recent research shows that downstream interventions, which focus on change at the individual level, are far more likely to increase health inequality than our upstream interventions, which focus on social change or policy change. According to the National Academy of Medicine, Mortality is affected by factors operating at the macro structural level. So state policies and corporations, also at the meso level, the workplace or the institutional level, and the individual or proximal level, such as health behaviors, socioeconomic circumstances. According to the National Academy of Medicine, macro structural level exerts a strong influence on other levels, on the intrapersonal, the interpersonal, and the institutional. For instance, state policies affect individuals' access to affordable health insurance. State policies can influence health behaviors through tobacco excise taxes, marijuana legalization, alcohol pricing, opioid prescribing regulations, and more. And state policies can influence individual socioeconomic circumstances through education expenditures, minimum wage levels, housing policy, taxes, and more. When the current health inequity challenges that we are confronting are viewed through the political determinants of health lens, tangible and meaningful steps within the scope of human control emerge. Actions that can be taken to better, more equitably, and justly protect and preserve the health and well-being of everyone. That statement, though, while true, is not meant to suggest that it is an easy or straightforward path forward. However, the political determinants of health framework encompasses myriad points of influence within and, of course, throughout social, economic, and political systems, such as voting, advocacy, commercial interests, government, and policy, among others, that independently and in tandem exert positive or negative pressures on all individuals and communities. You see, this complexity demands that the political determinants of health be considered in everything that is conceptualized, planned, organized, and implemented to more meaningfully reduce and, of course, hopefully eliminate the health and other inequities that have been plaguing our nation today. One of the things that I want to make about the political determinants of health model, it was my best attempt through a political science, legal, public health, and historical lens, looking at the levers that have been pushed and pulled to advance or hinder health equity, to understand what it has taken to get health equity focused policies introduced, to get them passed, to get them implemented, and ultimately enforced. Now, from this model, for sake of time, since I don't have that much time, once a perceived health inequity is identified, you have to conduct your due diligence to ascertain whether the health outcome is systemic. Is it avoidable? Is it unjust? How far can you venture to understand whether it is an institutional or a structural barrier that has been perpetuating or exacerbating the result? What is the policy change desired? And can you demonstrate the value of investing in change? Now, what does that mean? In our country, in the United States, as well as in other countries, advocates have to understand the disquieting and the harsh truth that the political determinants of health inequities have rarely been addressed unless their reduction or elimination served other purposes. You see, the success of any advocacy effort has depended on how palatable they are to commercial interests and whether there has been an investment value made to the government. So what do I mean? Oftentimes, we've had to make the economic and the national security argument. It is what we did to get 62 provisions in the Affordable Care Act, prioritizing health equity. It wasn't the moral argument, right? You can make that argument till your tongue bleeds, and it will not be considered unless you marry that with an economic and a national security argument, which is why we did the economic study that we did and that I talked to you about earlier. So think about that as you're moving forward in your advocacy, trying to figure out how we push and pull the appropriate levers to advance the cause of health equity. Let me break this down a little bit more now. Let's start with voting, the first political determinant. We know that when we vote, we decide who holds political office, and has the authority to make decisions impacting our health. These elected officials shape the policies that govern our health systems and our societal structures. Our votes can lead to policies that either expand or restrict our access to health services, as many of us know. By electing representatives who prioritize health equity, we can ensure more accessible and comprehensive healthcare for everyone, including addressing those upstream drivers of our health. Voting empowers us to have a say in the decisions that affect our health and well-being. It allows us to put in folks, the decision makers, who will then appoint others who will make decisions that impact our health. By voting, individuals can contribute to changes that reflect the needs and the priorities of our communities, especially marginalized groups in our communities. Finally, our votes hold elected officials accountable for their actions and policies regarding health. Voting ensures that our leaders remain responsive to our health needs and priorities. Let's think about this with an example. Efforts to make voter registration more equitable have helped to reduce key health-related inequalities. We know that the Civil Rights Act of 1964, the Voting Rights Act of 1965, through great research that Nancy Krieger and others have done, have found that 38,600 Black infant deaths were prevented alone by Title VI of the Civil Rights Act. And 20% of communities, of counties that were studied that were affected by the Voting Rights Act, 20% of the death rates among Black infants were spared because of the law. Voting absolutely matters, as we know. Let's look at the second political determinant of health. By closely examining the processes, the rules, the regulations, the norms, or other governmental practices, whether at the state, whether at the local, the state, or even federal and international level, researchers, practitioners, leaders may discover that health equity or an effort to achieve it is either facilitated by fair practices or stopped short, whether knowingly or because of a lack of understanding by the government. So let's break this down just a little bit more. Some examples of government rules and practices that have limited health equity-focused policies include the Congressional Budget Office, CBOs, analysts who refuse to score federal public health bills beyond the 10-year window. Oftentimes, we know that our health equity-focused bills, our public health bills, can achieve the long-term costs after 15, 20 years, but they are not allowed to be scored because of this arbitrary rule. We know that state preemption has been another example of government's interference, right, or interventions in limiting local or municipal legislative authority. We see that happening day in and increasingly so as we move forward. It's important to understand how state preemption has worked and how it has worked with the federal government over time in our respective movement. Third, let's talk about the third aspect of political determinants, policy. We know that the policy cements government decisions and is defined as a law, a regulation, a procedure, an administrative action, a plan, an incentive, or a voluntary practice of government undertaken to achieve specific health goals within a society. A policy provides another mechanism to enforce rights that have been gained or challenge those that deny our rights. It's another mechanism that can help advocates achieve greater traction in their efforts to advance health equity. Advocates should keep in mind that while they may have realized successes on this front, there are usually efforts underway to leverage the first two political determinants of health, voting and government, to void the results achieved in the third political determinant of health, policy. Okay, let's look at an example for this issue. When we think about policy, a great example is that there are these what we call facially neutral policies in the law. So many of you recall that prior to the early 1900s, there had been these racially explicit policies that were allowed to be passed, what we call explicitly racist policies that were denying social and economic benefits to Black and Brown members of our community, basically allowing them not to get advantage or take advantage of the resources, to leverage the resources that were being given to other population groups. Well, of course, there were at that point the creation of the National Medical Association, the National Black Nurses Association, the NAACP, and others that came in and helped to, through civil rights attorneys and others, worked collaboratively, harnessed that power of collaboration to say, wait a second, these explicitly racist policies are unconstitutional. They violate our Equal Protection Clause. Therefore, O courts, you cannot deny the truth and you must rule against such laws. They did, they succeeded. But then as we have seen moving forward, racists are very clever people. And this is exactly what they did using their creativity. We moved away now to facially neutral policy. So on their face, they do not deny economic and social benefits to any particular group, but they are crafted in such a way that they have the same effect once they are implemented. So the Social Security Act was one such law. We know that Dr. Perrin, who was the Surgeon General at the time in the mid-1930s, basically the mastermind behind the syphilis study in Tuskegee. He was the mastermind behind the syphilis experiments that were done in Central America and Guatemala with Guatemalan prisoners. This man worked with policymakers in Congress to create the Social Security Act, and he intentionally avoided allowing folks who were agricultural and domestic workers an opportunity to pay into the system and to benefit when they were of retirement age. We know at the time that 78.8% of African Americans fell into that one of those two buckets. And a lot of immigrant populations fell into those buckets as well. Latino and Asian Americans fell into those buckets and were denied. We see that again, time and time again, with the Highway Act that was passed, the Fair Housing Act, the list goes on. We've also seen this in many occurrences within the bundling of policy. So recently, researchers using an innovative counterfactual research design concluded that the growing disparities in working age mortality across states were due to growing differences in policy contexts and the bundling of policies, not to trends in states' educational levels or income levels, which is quite interesting. So as we saw in the 1960s, 1970s, where the states were coming closer in terms of life expectancy, once those policies of the early 1980s were allowed to take root, that focused on rugged individualism, that were really pushing that notion forth, we saw those states, primarily in the South, stalling on increasing their longevity, but those states in the Northeast and West that adopted an egalitarian or equity focus, we saw those states continue to increase their life expectancy. Something to think about. So when you put this all together with this tripartite definition, you get a sense of how myself and my colleagues, teammates, analyze various policies when we are connecting those to the health outcomes in a community, trying to understand which law, which policy has had an impact or has caused many of these inequities downstream. From redlining, if you think about structuring relationships, we talked about the HOLCA law. With redlining, you can see how that was used to structure relationships. You've seen the anti-miscegenation laws at the state level, again, designed to structure relationships by preventing intermarrying among whites and Blacks and Asian Americans. We've seen the blood quantum requirement laws for those of you who work with Native American communities, again, designed to structure relationships in that community and keeping them in an oppressive state. We've seen immigration laws steeped in racist ideology continue to thrive moving forward. And we have seen policies preventing children with disabilities from receiving an education in schools. Again, accessible housing, even to this day for people with disabilities, a disparately impacted group of people, being unable to realize that much needed resource, owing again to local policies and state policies in some respect. When you think about the distribution of resources, you can see here again, for those of you who've worked with Native American communities, the Pima Indians in Arizona and other tribes, many of you know the story of the Garrison Dam that was basically created by an act of policy that prevented the flow of water down to the Pima Indians, who had used that source, that water source, for generations to, farm the land, to grow their crops. And because that was cut off to them, all of a sudden, they had to change their lifestyles. To this day, they have one of the highest, if not the highest, rates of diabetes in the world. Again, you can connect it to that dam, but you need to do the equation and finish it and connect that to the policy that instigated it in the first place. Let me just close out by talking about the administration of power. Perhaps this is the most contentious of this tripartite definition. We've seen example after example after example in the United States of decisions that have prevented power from being equitably distributed. We've seen folks being restricted. We've seen redistricting, gerrymandering, restricting ballot access. We've seen voter suppression tactics, voter identification laws, minimizing opportunities for early voting, or the closing or moving of polling places in various communities. This is absolutely troubling because we know on the front end that voting can mean the difference between life and death if we are not engaged civically, if we are not allowed to engage in the political process. It does have dire consequences to our health and well-being over time. So whenever I am analyzing a health equity and a health outcome, whether it's an inequity or not, I think about them in terms of how they came to be in the first place. What was the policy that created it or has been perpetuating or exacerbating it over time? How did the policy or the political action or inaction structure relationships in the community? How have health protective and health sustaining resources been distributed in the community? And how has power been administered? Or what has been the level of political participation? How has it been affected by these governmental actions or inactions? Let's go a little more global now for a second. For those of you who work in the global health arena, I want to really elevate this a little bit, because as you can see from the examples that I gave overall, health inequities in the United States can be traced back to a political determinant, even when the inequities were considered to be the result of just environmental, social, economic, healthcare, or behavioral health determinants. But like the United States, many places across the world have been subject to the same determinants. And perhaps the most resonating example of how deeply entrenched these inequities exist in various parts of the world displayed themselves not too long ago. Of course, I'm speaking during COVID-19 pandemic that touched every single piece of earth and their respective communities. We know that the virus did not discriminate, right? The virus did not discriminate, no matter the geographical location, the color of your skin, or your socioeconomic status. But our social and our economic policies sure did discriminate, right? And had a compounded effect over time. What made the outcomes unjust and unfair were the systems that were either put in place or not put in place in the first place by people, whether historical or in real time. So let me give as an example, Brazil. We know that the Brazilian government at the time had denounced COVID-19 vaccinations, and it resulted in 622,000 deaths in that country. According to a 2023 study that was published in their epidemiology journal, it suggests that if 80% of the Brazilian population had been vaccinated by May of 2021, almost 60% of deaths would have been avoided in Brazil. But again, many of us who work in global health saw the result of decisions, political actions or inactions at that level in that country. Let's talk about the United Kingdom, another similarly situated country to the United States. We know that in this example, in England, in the year 2011, where the government introduced the Public Health Responsibility Deal, that was a public-private partnership which gave greater freedom to the food industry at the time to set and monitor targets for salt intakes. Let's think about it, salt intakes, right? What happened there is, unfortunately, the more the private food industry did, the more it did not adhere to stricter salt intake guidelines that had been set up by the government. And as a result of that, what did we see? The UK observed increased cases in gastric cancer and heart disease. And then after that, you see the government recognizing the less than desirable effects it has had on the country and has committed to pushing the public health in England, their system, to monitor the food industry's progress to the new salt reduction targets. So you can see how policy, there was an attempt, right, to, of course, deregulate the food industry's standards on salt intake by their community, by their population. And then all of a sudden, when the health impacts were becoming alarming, you see the government intervening again. But the point here is to show you from the political determinants of health model, how the commercial interests intersect, how they interact with the government, right, to influence our health outcomes. So what have we learned today? In closing, we know that targeted policy interventions approaches have measurably improved the health of many Americans, and that health equity is possible through policy action. Health policies that have focused on eliminating disparities and employing culturally tailored approaches, including childhood immunizations, breast cancer prevention and treatment, tobacco control, health enterprise zones, and maternal and child health, have all demonstrated this fact. So as you are moving forward in your quest to advance health equity, to move beyond nibbling around the edges of health inequities in our community, to do something that will allow us to really provide substantive changes for our communities, it's really essential that we think about these questions. First, what policy or policies created or mitigated the risk leading to the effects, positive and negative, that we see today? We know that many policies create immediate or clear impact on health equity, largely by mitigating or exacerbating structural racism and its effect. However, many policies impact health equity through more subtle means, often through a domino effect that ends in health inequity. So by engaging in this question with curiosity, and it's really possible to determine if there is a policy that created an effect directly or that created circumstances that allowed this to operate. We talked earlier about the context, right? Could the context be influenced by government? We need to think about those rules, the processes, the regulations, the norms, or other governmental practices, right, that basically hinder or advance opportunities for health equity and get them corrected. Third, we need to think about how advocacy and or voting play a role in improving health outcomes. Fourth, are the related commercial interests aligned with improving health equity, or do their pursuits create and or expand inequitable or higher risk environments? This is a broad question, and it could point to specific products, to marketing practices, to lobbying activities, location of industrial sites, environmental safety, pricing of key products, and it may interact with the government and policy questions that relate to issues like taxes, municipal budgets, inflation, employment or unemployment, and so forth. So that is a key thing in the analysis that we all need to consider. And lastly, how do the above political determinants interact or intersect with each other in this particular project or program that you are trying to advance? So some key questions to think about as you move forward in your journey to advance health equity. Again, I want to thank you all so much for the privilege of your time, and to Dr. Johnson for the invitation to present today. I am happy to entertain any questions that you all may have.
Thank you very much, Dean Dawes. This was indeed insightful and informative. So thank you for this valuable presentation. We will take a couple of questions from the audience. They are in the chat. So we will start with the first one, which is on the overturning of the Chevron decision, and what potential impact will that have on the political determinants of health?
Oh my God, whoever asked that question, thank you, because it is a major. It is the case that I have been following, along with the Grants Pass case that dealt with the issue of homelessness and penalizing people who are most vulnerable in our society. So those two together alarmed me once the decision was published. Now, in terms of Chevron, every health law scholar, that is one of the major cases that we have studied, right? Giving the authority to those in our agencies who are policy experts to interpret what the statute said, where there may be ambiguity or some issues where there may not be as clear as they would like. Well, what's interesting about this recent decision for me was back in the NFIB versus Sebelius case, the first case that was trying to undermine the Affordable Care Act. You remember that Chief Justice Roberts saved the law, right? The Affordable Care Act saved us. And thankfully it was not repealed, of course, through legislative action. But through his dicta in NFIB versus Sebelius, he acknowledged the role that jurists play. They have been trained, right, to really analyze, to interpret the law, but they're not policy experts. And he recognized that these policy decisions were best left to the people, right, to people who are experts in areas that focus on the provisions that the Affordable Care Act was addressing. Now, how surprising it is then to see basically the Chief Justice and other justices talk through one side of their mouth, recognizing that as judges, they do not have policy expertise, but now overturn Chevron and state that it is ultimately in the hands of the jurist, the judges, right, to interpret, to give final interpretation of a policy that has been developed by Congress or a legislative body. This is interesting to me too, because I anticipate there will be greater litigation when a commercial interest, right, is not pleased with the results or the decision, the regulatory decision. They will use that as another tool in their fight to overturn equity-focused policies. So it will have grave implications for us who are in the health policy realm. And we need to be thinking about, as we are crafting policy, it is so important that we understand, the legal frameworks from an originalist standpoint in terms of how they have interpreted the Constitution. We need to think about the textualist approach and how conservatives have used that framework to interpret statutes. When we were working on the Affordable Care Act, when I worked on the Mental Health Parity Act and the Americans with Disabilities Act Amendments Act, we thought about, how textualists, how originalists would deem certain provisions of this equity-focused policy. And there's a reason why we did not include report language with it. We did not want to include the report language expounding on what was in the four corners of the legislation, because we understood that it could come and hurt us should folks engage in litigation to undermine the law. So we need to think very strategically at all fronts when we are developing the policies to address the inequities in our society. Very good question. I hope that helps to give some color to what we can expect. Thank you, Donna.
Thank you so much.
Kimberly, it's great to see you, Kimberly Williams.
Do we have time for one more question? If we do, there's a question here about looking at policies. You mentioned policies, tracing back to the policies that have led to compounding effects over time as a foundation for designing equitable policies. Quickly, if you could, in the context of climate and health, which should be the single most important consideration or few key priorities when designing local or state policies to ensure that equity is at the forefront?
As we're doing that, I'm going to use my lens because I live in the South, and in the deep South, we have a lot of climate change deniers, as you can imagine. How do you convince folks who ideologically, right, are not folks that maybe embrace the science and trust the science? And for me, as I have spoken to health commissioners, to lawmakers in Tennessee, in Georgia, Florida, well, not really Florida, that's not true. It's Georgia, Tennessee, and Kentucky. As we have spoken to those policymakers, we have come in with the economic argument to say, here's what we're pushing. So you have to be as wise as a serpent and harmless as a dove, as we all know, right? When it comes to crafting the policy and getting them to introduce it and to actually implement this. And so when we have come to these lawmakers in the South, we have used that economic and that national security argument, making the case for why. And then we've also, sometimes I'm not, married to a certain term of art because I know it'll be off-putting to these policymakers. And so we craft it differently depending on the audience. And that has allowed us to at least get some piecemeal policies passed, not the comprehensive policy that I would love and others would love, right? Comprehensive and reticulated policies, but at least it affords us a foot, right, through the door and gives us as a chance to continue to build upon that. I think a part of this too is understanding the power of alliances, of coalitions, and recognizing that education and of course advocacy go hand in hand. You have got to get those numbers. What we recognized as we were crafting the Affordable Care Act, pushing the Obama administration to advance equity-focused provisions was that, you know what, if we didn't have the deep pockets, so we couldn't influence that way, but we had to keep expanding, building our national working group with coalitions, alliances, and others to come together to present the numbers so that the Obama administration and members of Congress would listen to us because they were so fearful about including provisions that were health equity focused, thinking that it might be a turnoff and it might actually undo the health reform law as a whole. So you have to, again, even if you have a government that is sensitive, I still think it requires us to be very strategic and to understand the type of language that has been used throughout history all the way until today that have succeeded. The ones that have made the moral argument. So when Dr. Satcher presented his findings that there are 83,000 people dying each year, as Surgeon General and as Assistant Secretary of Health, he recognized that even in the Clinton administration, he had to figure out how to make that economic argument, right? And how to tie it to the national security argument in order to create his national disparities, racial and ethnic disparities initiative with Secretary Shalala to go out and get the government to at least employ the type of, or at least enact the type of policies that would allow for us to, again, make some headway in communities. So I will just say all of that to say, I know it is a very complex system that we're operating. There are numerous things that we have to consider. The system was designed to be complicated, right? To burn us out, to make sure that the status quo remains supreme. But I do think it is important that we continue to educate ourselves on these pieces. And I will just end with a quote from Satcher, since I've been invoking his name. You know, I love the man dearly. I have been fortunate to be mentored by him, and I love him. And he has said something that has resonated with me time and time again, that as leaders who care deeply about health equity, first you have to care about our communities, right? Then you have to know enough, right? You got to have the courage to do enough, and you have got to persevere until the business is done, right? We have achieved the result that we want. First, you have to care, but as we have heard today, caring is simply not enough if you do not know enough, and if you do not have the courage to do enough and persevere. And I want to leave that with you to think about. I hope that this sense of pessimism that I've observed with many of my colleagues, I hope that some of that will be dissipated after today, because you are empowered, you are knowledgeable, you know this. Let's keep sharing this information with our communities and help them in the struggle for health equity. Thanks again, Dr. Johnson, and thanks to all of you for the privilege of your time. I appreciate it.
Thank you so much, Dean Dawes. I know we wish we could have this discussion going much longer, but we are appreciative of your time, and we will wrap up today. And I hope you all found this very helpful. Our next webinar will be on August 9th, and will cover transportation and energy conservation. And there is a link in the chat to complete the webinar survey. And the code for CME credit is 13221 that will be placed on the screen. Thank you again for joining us. We are now concluding our session, and thank you again, Dean Dawes, for an amazing session.